I'd now like to welcome our second speaker, Bart, Leroy, who will discuss Dr. I Can't See to Read, Retinal Structure and Function. Bart is the chairman of the University Hospital in Ghent in Belgium. He's an outstanding electrophysiologist, geneticist, clinician, and human being. Bart.
Hi, everyone. My name is Bart Leroy. My brief is to talk to you about Dr. I Can't See to Read, and then talk about structure-function relationships in disease affecting the central part of the retina. So this is the overview of what we're going to do. Obviously, in the space of 13 minutes, not every condition can be addressed. And so these are the conditions that I'll be zooming into, giving you, I hope, a good view of what is structure-function relationship in the central retina. Before we jump into that, rods and cones are a topic that one might just do a quick refresher on. We have about 120 million rods per retina, and they give us navigational vision at night and do not function in daylight. The cones are about 6 million, so 20 times less than the rods per eye, and they give us sharp vision in daylight. They give us color vision, but they're also responsible for the color vision at night. So let's first look at the condition called Stargardt disease. Patients will generally present with early visual loss. Signs in the back of the eye will be the beaten metal type fovea. Some people will already have yellow-white deep intraretinal flecks in a fishtail-like manner. Chorioretinal atrophy is seen later on. But initially, you can be fooled and the retina may look normal and people may think this is functional visual loss. So this is a genetic condition that is always due to mutations in both copies of the ABCA4 gene. It is an autosomal recessive condition, so finding just one mutation in one copy of ABCA4 is not good enough. What does the protein encoded for by the ABCA4 gene, which is also called ABCA4, do? Well, it moves, as you can see in this slide, the fuchsia rose or pink protein, ABCA4, moves used vitamin A in the outer segments called all transretinal out into the interdiscal intracytoplasmatic space for it to then get into the interphotoreceptor matrix and then into the RPE so that it can get recycled. If you don't do that, it accumulates in the outer segments, it'll degenerate into toxic products and therefore cause disease at the level of the outer retina. A classic phenotype of what is Stargardt disease is seen in this lady who presented the condition later on in life, but it still is very classic. You can see the flecks, you can see that they focus in the macula and around. But you can have other types of Stargardt disease. On the left, you see someone who is barely affected, but did complain of visual issues. In the center, you see the early stage of classic disease where the flecks are yet to come, and atrophy can be seen in the central macula. And on the right, you see a late stage severe disease where atrophy of the retina is much more extensive than just in the macula. So when we do electrophysiology, we will find in the majority of cases a normal full-field flash ERG testing the generalized retinal function. What we also will have is a pattern ERG that will always be abnormal. Now, let's illustrate this with a case. You have to, as a differential, think about other conditions, including Batten disease and cone disease. We'll talk about those later on. So let's first look at this 10-year-old girl, unexplained loss of vision, referred by a fellow ophthalmologist who was querying whether this could be potentially a functional visual loss. And the father's jailed 6 months prior to the consultation. So there are all kinds of reasons why it could be stress-related or functional. So this is the fundus. You can see that both eyes in the central part of the macula have this greenish yellowish hue, which is very suggestive of early stage Stargardt disease. We do a full field flash ERG, normals at the bottom for you to compare. At the top, you can see that the traces are essentially normal. So the generalized retinal function is normal. But if you zoom in over time into the central macula, you can start to see the white flecks appear in the maculae around the center, where you can see that white flecks start to pop up on this blue light autofluorescence image. When you do a pattern ERG on the top right-hand side, initially 1 year after the first visit, actually, you can see that the P50 expressing input into the retinal ganglion cells, so photoreceptors basically, you can see that down from what is normal. And over time, at the bottom right-hand side of the slide, you can see that it's all flat. The N95 is specific for ganglion cells. They don't get much input if the fovea and perifoveal macula are not working properly. So this is very suggestive of Stargardt disease, and the clinical picture becomes more clearly in keeping with Stargardt disease. So this is Stargardt disease diagnosis, not functional visual loss. So let's look at another condition. Let's look at something that primarily affects the retinal pigment epithelium. And we are now talking about Best vitelliform macular dystrophy. It is a condition that is typified by the presence of an egg yolk-like lesion in the central part of the retina, and visual acuity declines but remains fair in at least one eye until later on in life, say 40, 45 years on, depending on the patient, but that was generally seen in systematic studies. But all people in the old days, now we think the large majority of the people have an abnormality on the EOG electrooculogram. So there are people who classify Best vitelliform macular dystrophy in stages. We're not going to do that in this talk, but here you go. You see on the left an early stage at age 7, photos taken in the old days by my predecessor, Professor Delay, shows you beautiful egg yolk-like lesion. And over time at age 50, that is 43 years later, you can see that it does change over time towards a vitellioptive phase, as you can see. What is BEST 1? It encodes bestrophin, and there are 4 BEST genes. BEST 1 encodes for a regulator of RPE calcium channels. Some people say these are chloride channels. Some people say they're calcium channels. We think that it is a calcium-activated chloride channel in the basolateral surface of what is the RPE. The Best vitelliform macular dystrophy is just one of what we think are 3 different bestrophinopathies. We can't go into it in detail here. What you can see here is abnormalities in the central retina in a case. Typical egg yolk-like lesion, and EOG is flat. The light peak to dark trough ratio is abnormal. All the rest is normal. So this is Best vitelliform macular dystrophy, and we've proven that through molecular screening. So let's look at the next condition affecting the central part of the retina. So what's X-linked RS? It's a condition that basically affects men due to a mutation on the X-linked gene RS1, and RS1 encodes retinoschisin, retinal glue that keeps together all the individual layers. They present with loss of central vision. All of them have some sort of central retinal abnormality. Some, 50%, have retinoschisis in the periphery, as you can see, and some are born with a retinal detachment. Here you see typical signs of both the central part affected by this cartwheel appearance of retinoschisis, and the periphery can be scytical as well, as you can see at the bottom side. Visual acuity can be normal, but most of them at school age will present with loss of vision. As I said, RS1 encodes retinoschisin, basically retinal glue. We're not going to go into the details here, but here you can see that the splitting of layers, which is schisis, is more prominent in the central part, but it actually goes way beyond it and is present at several levels when you look at the OCT. But let's look at a case, a 49-year-old gentleman who's never been perfect as far as vision is concerned, and he's complaining of loss of vision lately. He's worried about his son's future. In his pedigree, you can see that there's potentially X-linked disease. This is him, best corrected visual acuity 110 both eyes. You can see on the Goldman's that centrally there's a scotoma. And here you see small whitish flecks in the central macula. If you go beyond that, there's nothing to be had. If you look at the left eye, the same thing is there, little white dots in the center, and then nothing to be had in the retinal periphery. You can see that much better on near-infrared reflectance and blue light autofluorescence image, but they don't add anything to the case really. You can see on OCT, however, that the central part lacks the photoreceptors that you would expect still to be present, and there's surely not any scythical change at all anymore. What you can see, however, is this on a full field flash ERG. And this is an electronegative ERG. And an electronegative ERG is typical of X-linked RS. And so this is a late stage disease where you don't see the cystoid degeneration of the retina anymore. The splitting is not apparent, but you lose outer retinal cells, the photoreceptors, and vision goes down even more. X-linked disease, proven not to be a risk for kids. Let's look at cone dysfunction. Generally speaking, problems with cones. Here you see 9 genes, 15 genes, and 1 gene, depending on dominant, recessive, and X-linked. You can see that they're involved in phototransduction, they're involved in transporting the photoreceptors, in development of photoreceptors, in phototransduction again, in structure, and even in vitamin A recycling. All of these genes can be at the basis. Let's look at an example again. Goldman visual fields, full, but they show an issue centrally. Color vision's really bad in this gentleman, and you see a central bullseye lesion. This is typified even more on blue light and near infrared reflectance or autofluorescence image and reflectance imaging. And if you look at the, ERG, you can see on the right top hand side of the traces that the cone specific responses, the single flash and the 30 Hertz flicker are the most affected. This is a gentleman with a central lesion, central visual loss, but he has cone involvement throughout the retina. Here you can see the center, and you can see that it is devoid of many of the photoreceptors that you would normally like to see present. He's proven to be X-linked cone dystrophy, RPGR mutation, and proves the case, basically. The last thing that I want to just quickly dwell on is achromatopsia. No cones work genetically, and we can have that due to 2 mutations in any of those 6 genes on this slide. We can't go into them in detail, but suffice it to say that the majority of them is involved in the phototransduction at the level of the cones only. So the rods seem to work, but the cones don't work congenitally. They are still there, but they don't work. What you can see here is actually a fairly normal looking retina at all levels with all kinds of multimodal imaging. And in the ERG traces, you can see that the right-hand side is flat. There's no cone-specific responses, neither on single flash nor on 30 Hertz flicker stimulation, whereas the rods are normal. Here you can tell on OCT that some of the people at the bottom example, for example, have issues with central photoreceptors. So those cones are not present anymore, whereas they are probably present beyond that central macular lesion. In conclusion, I hope to have shown you that we have progressive and stationary diseases. Achromatopsia doesn't really change much. Solitary, but we have to think about the fact that some of them can be syndromic too. And then photophobia, night blindness, these are all things you have to talk about to your patient. Classic Mendelian inheritance patterns are applicable, and so therefore do draw pedigree. It'll enlighten you as far as problems of the patients are concerned. And patient history taking, as I said, is crucial. Genotyping has to happen to confirm the clinical diagnosis. With that, I thank you for your attention and enjoy the rest of the course.
Thank you very much. The audience seemed to be rather reluctant to ask questions. So perhaps I could ask one. We're now using autofluorescence imaging, OCTs regularly. How often do you think we should be using wide field autofluorescence?
I think it is very helpful. So there's an additional value in the sense that I'm immediately thinking about autosomal recessive bestrophinopathy due to 2 mutations in BEST1. You can definitely see changes far out in the periphery that are not that you're not able to catch with 55-degree fields. However, I do not yet have it. I'm definitely going to invest in it. But I'm still very much able to do my clinics without. So I think the autofluorescence in the central part is much more important than it is in the periphery. For those acquiring instruments that allow you to do autofluorescence imaging, I would say have a look at the wide field immediately.
May I ask a question?
Of course.
Sure.
Thank you. I was just wondering, what guidance or what are your guide points for signposting electrophysiology? When you have a structural abnormality, do you ever think, oh, that's fine, I know what that is? Or would you normally go into electrophysiological testing?
I would say the evaluation that we do in our genetic ophthalmic clinic is one where imaging is virtually never on its own. So I think that I hope that during the talk I've shown that some things may pop up in the center, but actually when you then do generalized screening or screening of the generalized function, you are so much more easily guided towards the correct diagnosis that I cannot possibly see a role for just imaging in any of the really thorough clinics that we ought to be doing at academic centers and larger centers that are non-academic. So personally, I believe that functional testing should go hand in hand with evaluation with imaging. By all means. There's a question I see in the Q&A, which is Panagiotis Salvanos, who is asking which color vision test do you prefer clinically? So we in Ghent, Panos, what we use is basically a combination of the Ishihara. Obviously, that's only able to pick up red and green abnormalities. We do a Hardy-Rand-Rittler and we do a panel D15. If you have one of them, I would say probably Hardy-Rand-Rittler. Because that is able to tell you something about red-green deficiencies and blue-yellow deficiencies, and is able to show you some level of degree of involvement of those color vision axes.
But would you use the desaturated or the saturated D15?
I think that in daily life, in the daily clinic, the desaturated one doesn't have much of an influence on clinical decision making. It is very subtle what it shows, and so I think I don't know whether you have tried it, Graham. I've tried to do the panel D15 desaturated, and I'm not certain that I'm always scoring perfectly well. So I think it is quite hard. There's another question. I don't know whether there's time. Once you diagnose an inherited retinal disorder, do you tend to follow up patients by electrophysiology? Yes, I do. Do I? So yes, I do, by all means. So I think that electrophysiology is one means together hand in hand again with the imaging to follow up how the phenotype in a patient evolves. And I'm not saying that at each visit I will do both. I will do as a minimum the imaging, but definitely, for example, an RP patient who comes in every year, I will probably do every 2 to 3 visits, I will do electrophysiology. Obviously, if the ERG is flat, it's not going to come back. But in people with remaining function, I certainly use electrophys as well.
Do you use it at all in a prognostic fashion in that degree, Bart? The rate of deterioration, possibly the extent of delay in a flicker ERG in an RP patient?
I would certainly, and I would certainly also do so in those cases of RP that are known to be very variable in expression. So some of the conditions are known to be very variable from one person to the other. PROM1, for example, is very classic. It's not that every person is as affected as the worst case. And sometimes you get people affected at 45. Some people have disease in the same family at age 5. So I certainly would do that. What machine do you prefer for autofluorescence? I'm not paid by any company. Personally, I think that the Heidelberg Engineering HRA is a very good one. I think that that is the most dispersed throughout the world. And so for studies, for example, it's the one that people ask, whether you have that. But there are many others that are pretty good, actually.
Yeah, not all of them have the right paradigm in the sense that the optic disc, because there's no photoreceptors there, should be black. But in many of them, I mean, we have a variety of, in the different hospitals I work, a variety of different autofluorescents, and a number of them, the disc actually is white, or at least it looks as if it's reflected.
I fully agree, Graham. Yeah.
Whereas the spectralis is much better.
You can do a bad job with the spectralis as well by upping the sensitivity. So what Graham is saying is absolutely true. So a proper autofluorescence image using blue light, you can also do it with near infrared light, but with blue light, where you highlight lipofuscin content at the level of the RPE, you have to have a black optic disc, as Graham is saying. So I think probably that ends the Q&A session.
Thank you very much, Bart. Thank you.
Thank you.